Hello, welcome to the second part of this online lecture series. This is going to really be just a brief description of how we actually examine the knee, how we go about the process of knee examination. So we'll walk through history, inspection, maybe some palpation, very little special tests, but mainly history and inspection. The palpation and special tests will come in the lab component of the course. And I want to just say before I start this lecture that history, of course, should include the common questions. What I'm doing now is adding knee-specific historical questions that we should include in the history part of our examination for a patient who walks in with a knee pathology. So please know that I'm not saying don't ask any other history question. I'm saying that these are questions to add to your actual historical component to the patient evaluation. So one of the things that is a little bit different when we're taking a history of a knee patient is we want to know about the forces that happened at the knee. So we have to be very strategic about how we ask that historical question. We can't say, oh, did you have a force that happened at your knee? I wouldn't know what that is. But you can ask questions like, did you take a blow to the knee? On which side did the blow actually happen? If you didn't take a blow, did you cut? Did you twist? Those are all different ways to figure out the type of force that happens at the knee. And the reason for that, in the knee in particular, it becomes important because the forces can help us kind of start ruling out injuries that it isn't and ruling in injuries that it is. So here's an example. If I take a lateral blow to the knee, that is most often associated with a valgus load to the knee, and I can assume that I have to check the MCL. But then I know that the deep bundles of the MCL attach to the medial meniscus, so then I know that I have to check the medial meniscus. Make sense? But I'm not out of the red zone with the LCL, because if I took a blow to the lateral side, there's a compressive force that happens, so I still need to make sure that the lateral structures are intact, right? We can have a shearing force. Remember we talked about the shearing force where the tibia and the femur slide across one another? And in a shearing force, we could have lots of things happen. We can have bony injury, right? We can have injury to either menisci, right? We can have injury to the collateral ligaments. And then we can have rotary forces about the knee. Now, rotary forces are the ones that, to me, are going to be most catastrophic. Rotary forces mean internal, external rotation of the femur and or the tibia across one another. And we know with rotary forces, the ACL is injured most often, but then the meniscus are most often injured that way as well. So we can see how learning the direction of movement, learning the type of force will help us rule in the injuries. This is kind of where I talk to you guys like clinicians, right? It's this concept that if you are going to be a clinician, then you have to understand how the body actually works, right? What forces would cause this type of injury? What force would cause this type of injury? Because if you're thinking like that in an evaluation, then you're going to null it every single time because you won't be stuck looking for all of the injuries. You'll be stuck with the small set of injuries that you know it has to be based on the mechanism of injury, right? So creating efficiency in your history asking will then create efficiency throughout the entire evaluation. The location of the pain becomes instrumentally important too. So asking the patient where their pain is becomes extremely important during a knee eval, and here's why. What we know about certain ligaments in the knee or muscles in the knee is that they present a certain way almost every time the injury has happened. So if we're thinking about the ACL, for example, let's take a look at this. If I'm an ACL and I have an injury, most often I'm going to report pain that's just beneath the kneecap, right? So if I'm looking from a lateral perspective, my pain is most often going to be right here. They're going to say, oh, I have pain like right here. I have pain right here, right? Or on the inside of my knee. So this is an example of how location of pain becomes important to helping you figure out what pathology is. For a PCL injury, one of the interesting things that we see in the literature is that the gastrocs start way down here, right, at the Achilles tendon, come up and proximally have an attachment to the posterior aspect of the condyles. So we know that they come up and they cross the knee joint. What we've seen a lot of times is PCL patients will report pain in that region. And so it becomes important to ask, where's your pain at with the PCL injury? If they point here, we have to rule out gastrocs, and we can do that with manual muscle testing, right? And then we have to figure out if the PCL is actually involved. And then last but not least are the menisci. We know that the menisci are cartilaginous structures. We just talked about that in the anatomy video. What we also know about the menisci is that the periphery or the outer portion of the menisci get fed blood through external structures, right? And so what we know about them is because they're more superficial, that you will have palpable pain within the actual joint line. So we'll be able to palpate the pain for a peripheral or a peripheral injury. But for those menisci injuries that happen to, right, the avascular portions or the inner portion of the menisci, most often those patients are going to complain of like clicking, locking, and popping within the knee. So again, that gives you a telltale sign. Are they tender palpation on the outside? Are they having locking, clicking, and popping? That kind of helps you determine what type of knee pathology that patient actually has, right, you guys? So these all become important questions to ask, but it's not just the pain question. Give me a scale of 1 to 10. It's like, no, tell me where it actually hurts. This is an important component for us, you guys, if we want to figure out what types of injuries that patient may have. Okay, so next on the list, I know you guys are like, Dr. Cosby, why are you giving this to me? Poor prognosis and knee pain. Here's an evidence-based approach. You're all in an evidence-based class, and if you are taking a history on a knee patient, then these are questions that you have to ask your patient, because what we know is that as the number of yeses go up on this list, the more poor the prognosis is in terms of outcomes. The longer they might take to heal. Maybe they won't heal at all. Maybe they'll re-injure themselves. And so this list, based on the evidence, is if they have a higher disability, so more ligaments involved, more muscles involved, more swelling involved, if they've had a long duration of pain. So is it 1 day or has it been months? Right? And just think about that. If there's a long duration of pain, there are lots of things that we have to consider. What's driving the pain? Why hasn't it gotten better? Have they gotten treatment? So longer duration of pain is a predictor of poor prognosis following any injury. More pain at baseline, of course, unless we just have the patient sitting in front of us who just has zero pain tolerance, right? Previous history of a knee injury, surprise, surprise, just like with the ankle injury, what we know about knee pathologies is that if they've had one knee injury, it'll take longer for them to heal or to recover from the second knee injury. Patients that are older, obese, and suffer from anxiety. And I want to talk about the anxious part, because what we know in the research literature when we look at anxious patients and injury is that once they have an injury, the recovery process becomes a lot longer, because now we have to not only work on the injury, but also work on the psyche of that patient, convincing them that they can return to sport, return to work without re-injuring themselves again. And you'll find that it takes longer to do that with a patient who's been diagnosed or suffers from anxiety. So this list is an evidence-based approach to helping you get through the history questions. What does your life look like? What aren't you able to do? How long has the pain been? On a scale of 1 to 10, when you first injured it versus now, what's it feel like? Have you ever injured yourself? And I skipped this one, not intentionally, I promise, but to save it for last. What we know about knee injuries, particularly ACL, PCL ruptures, knee injuries that are going to require surgical intervention, is that those patients who do not have a support system, a roommate, a spouse, a significant other to support them through the process, have poorer prognoses over time. They don't heal as fast. They don't return to play as fast. So social support becomes extremely important for your patients. Okay. In terms of inspections, we'll do an overall approach, and then we'll get into some more detailed approach. But go back to the gait lab, you guys. I hope you're all tying this in. So we're really want to focus in on gait, in particular with these patients, and static posture, because a lot of times that will tell us why they actually had the injury. So essentially, we're going to look at static, of course. We're going to look at the overall impression. What does our patient look like when they're just standing? We're going to get that still shot. And we're obviously going to do that from anterior, lateral medial, and posterior. And then we're going to go into gait. And you guys just turned in your gait assignment, right? And what we know about gait is there's changes that happen that we can't see in a static posture. So let's take a look at this patient. And we can see right away, right? You guys are all gait experts now. What's happening at the knee joint? If you said they're falling into genu recurvatum or knee extension, you'd be right. What would we expect this patient to suffer from in terms of an injury? What would this gait tell us if they came in and they had a catastrophic knee injury? Which injury of the knee do you expect would occur in this patient? We could predict a PCL injury, right? Because with genu recurvatum, what do we see? Massive tibial posterior translation, right? So watching gait is an extremely important aspect of evaluating a knee posture, right? In the ankle, I didn't say that, did I? In the knee, it becomes instrumentally important to do your static posture and your gait assessment. Okay, so in terms of inspections, let's look at the anterior part of the knee. What we're looking at here is, are the patella aligned? Are they malaligned? What do they look like? Are they sitting in the trochlea of the femur like they're supposed to, right? So are they sitting in the trochlea of the femur like they're supposed to do? Are they articulating with that femur? For patellar tendon, what does it look like, right? The patellar ligament, is there swelling? Is there thickening of it, right? The quadriceps tendon, I do the same thing. Is there thickening? Is there tenderness to palpation? We want to compare the quadriceps, and I would even argue the hamstrings. And then last but not least, the tibial tuberosity. We want to look at the tibial tuberosity, right? And see if we have any swelling, because that could be a sign of Osgood-Schlatter's disease. So on the anterior aspect of the knee, these are all of the things that we're looking at. Now, I've skipped a few things because I think we'll look at other static postural assessments and know what we're supposed to be looking at. But essentially, posteriorly, like you guys can see, like, what are we seeing here? Genu valgus at the knee, right? Knock-kneed approach. Again, we're not posterior, just anterior. So we'll focus on patella position, quadriceps atrophy. Yes, we're going to focus on looking at patellar tendon and tuberosity. We'll then go to look at kind of the medial aspect of the knee. And so on the medial aspect of the knee, we're looking at swelling in the joint line, any discoloration, which would indicate like a crushing or force or a direct blow. Want to look at the the pes and serine tendon insertion on that tibial plateau. And then really, truly, we want to look at that vastus medialis. Is it small or atrophied? Is it hypertrophied? What is it? We need to know these things. These are things you're looking for in a knee assessment. On the lateral aspect of the knee, what we're going to be looking for is any swelling or discoloration, just like we did on the medial side of the joint line, the knee, the tibia. The biggest thing that we're looking for here, quite honestly, is the genu recurvatic stance. And we want to compare it side by side, because what we know is that a patient who has a PCL injury, the cool thing about it is you'll see more genu recurvatum on one side than the other. That would be indicative of a PCL injury. And then again, we just want to look at genu recurvatum. Now, of course, from an anterior perspective, I showed genu valgum, but you certainly could have a patient who's bow leg, right? Or has genu varus as well. And then from a posterior perspective, we can look at the hamstring. We can look at hamstring length. We can also look at swelling in the popliteal fossa. So you can see that here. We want to look at the gastrocs, and in particular the gastroc heads and how they insert, and certainly look for any bruising. Some would say that you can see genu recurvatum from the posterior aspect, but in fact, I like to look at it from a lateral aspect to really truly see that genu recurvatum. Next, let's talk about genu valgum. So what is genu valgum? Genu valgum is knock-kneed, right? Or the progression of the femur into the midline, and then you can see the tibia kind of going outward. Some would call it the knees touching each other. What are the causes of a genu valgum? So there are lots. It could be congenital. Most often it could be glute med related. Congenital wise, a leg length discrepancy. Certainly could be, so think about this. The vastus lateralis is going to work to do what? The vastus lateralis, IT band are all going to work to kind of create lateral stability. So if you're weakening of those structures, then most often you'll see a massive genu valgus load, but most often we see a weak glute med as the culprit for a genu valgum. Am I saying that's the only reason it happens? No, but it certainly is the case most often. And then what are the consequences of a patient who is genu valgus? Well, what we know about this is these patients, if they participate in sport, are at a higher risk for ACL injury, are at a higher risk for foot injuries because this places the foot in a massive pronated position, right? So we have foot and ankle injuries, but the biggest risk at the knee is to the ACL. On the opposite end of that spectrum is a Genuverum posture or a bow-legged posture. We can see that there. The causes of Genuverum most often are congenital. It's a bony abnormality that occurs. And then the consequences to a Genuverum most often are going to be meniscal related. So a lot of meniscal injuries and LCL injuries. And then at the ankle, we certainly see that the foot is going to be in a more supinated position. So we see an increased risk for ankle injuries and base of the fifth fractures. As we look posterior, we have genu recurvatum. Genu recurvatum, as you know, is hyperextension of the knee. Causes of this, well, man, you guys can see it, right? Massively lengthened hamstrings and gastrocs, certainly. You can also have with that associated with that changes at the pelvis for sure. But this is also most often congenital, most often seen in females, and in some instances is actually hormonally related. So in terms of consequences, the increased risk for PCL injury, we also see an increased risk for head of the gastroc strains and tendinitis. So we can see, like, as we're going through this evaluation of the knee, we've talked about the anatomy and how knowing the anatomy is extremely important. But then as we get to the evaluation of the patient, knowing the forces and really truly focusing in on that static and gait postural assessment will help us prevent future knee injuries from occurring. Next, we will transition into actual knee injuries. Hope you guys have a wonderful day.